Hello, we are here at IMW 2015 in Rome for eCancer TV. I'm Joy Ho from Sydney, Australia, and I'm joined by my colleagues, Professor Hatake from Japan, Professor Yoon from Korea, Professor Ho from China, and Professor Lee from Korea. We're going to have a discussion about what we've learned and what we do at home. So I'd like to start by talking about how we treat transplant-eligible patients. I guess two of the most common regimes that we all use are VCD and VTD, and for transplant-eligible patients, and then proceed to transplant. I can say in Australia that the majority of transplant-eligible patients are transplanted, but I gather there's quite a lot of heterogeneity in different parts of Asia. So I'd very much like to hear what you in your countries do, and also about your induction regimes. Professor Hatake?
Yes, we do using a VCD regimen as an induction chemotherapy before the autologous stem cell transplantation for transplantation eligible patients. And after the 4th cycle, we can harvest the prepared stem cell. And after that, we perform the stem cell transplantation. After that, it depends on the clinical research or not, but they usually move to the lenalidomide maintenance. This is the first line, and that's we usually do.
And induction, you use VCD mainly. So do you consider the use of a combination of a proteasome inhibitor and an IMiD? So for instance, substituting cyclophosphamide with an IMiD? Is that possible in Japan?
As a clinical research, I actually VRD regimen too, but it's only in the clinical trial setting. Yeah.
Similar in Australia, where we are unable to use a proteasome inhibitor and IMiD together. Yes. Perhaps I move to Professor Yoon in Korea.
In Korea, so far we have not been able to use velcade-containing agents as an induction chemotherapy for transplantation eligible patients. So far, therefore, we have used the thalidomide and dexamethasone as an induction treatment. As of next month, that is the beginning of October, we will be able to use velcade-containing agents for transplantation eligible patients in the form of Veldex or VCD. And so far, the mainstay of chemo is Taldex for transplantation eligible patients under the age of 65.
Yes.
The age limit for reimbursement by the government, funded insurance agency.
So that's interesting because, as we heard today, there are groups which are transplanting until age of 78. In fact, one mentioned for us, we would transplant up till 72 or 3, depending on biological age. How about Professor Ho in China about the induction and transplant?
Yeah, we prefer using VCD for induction and leave the thalidomide for maintenance after the transplantation.
Yes.
Yeah. Some doctors
combination proteasome inhibitor and IMiD at induction, is that possible?
Some doctors like to combine the proteasome and thalidomide together in induction.
Sure.
Yeah.
And Professor Lee in Korea as well?
Professor Yoon already mentioned to the Korean situation. Actually, our country can cover insurance from next month. So before that, our main standard care is thalidomide-based regimen.
Yes.
Actually, I prefer the CTD instead of TD. So actually, we would like to combine the alkylating agent to the thalidomide. Former time, we use VCD regimen. There's a clinical trial underwent by the Austrian group. At that time, we have experience to 20 patients in my institute. Actually, I understand that VCD regimen is very well tolerable and very nice regimen. In From next month, our country will provide some insurance in the regimen of VD and VTD.
Yes.
So we are worried to some toxicity of VTD use, such as some kind of peripheral neuropathy. Yeah.
It is interesting in Japan that you said that you are using lenalidomide maintenance as standard now. It's certainly not available in our country yet. It's only used for relapse refractory, but I guess we can use that to think about the transplant ineligible patients, but we hope that according to the data of the first trial, we will be able to use Lendex as first line. I wonder, how do you treat your transplant ineligible patients in Japan and Korea and China? Yeah.
Well, actually, in Japan, half of the cases associated with lenalidomide maintenance, but it depends on the medical insurance coverage.
Okay,
so then
not everyone.
Not everyone. So then we are waiting for the first line chemotherapy using RD.
Yes,
yeah,
sure.
not yet.
So in our case, in fact, for transplant ineligible, we also very much use VZD as well as bortezomib base rather than MPV according to VISTA. But I guess we consider it interchangeable, not that it's particularly proven. How about in China and Korea for transplant ineligible
patients? Well, because of the government regulation, over the age of 65, transplantation is not reimbursed by the government, called HIRA, Health Insurance Reimbursement Agency. Yeah, based on age. And over the age of 65, therefore, we can apply VMP as a first-line treatment.
But not
just like in VISTA trial. If they progress after barricade-containing agent, we can apply Lendex, lenalidomide dexamethasone, as a second-line treatment.
Okay.
So it's based solely on government regulation, not on scientific basis.
Yes, I understand. Yes. And in China?
Yeah. For transplant ineligible patients, generally we don't use morphine and prednisone because morphine is unavailable in China, you know. So we generally use the VD or TD or VCD or TCD.
Korean situation, we set the regimen and the cycle to treating transplant ineligible patients.
I guess along those lines, I mean, I have heard, for instance, that the rate of transplantation in transplant eligible patients could be reasonably low. Indeed, we heard even in the US, depending on the institution this morning, that the rates may be as low as 60%. We are collecting data in Australia as to what our actual rate is, because there are differences between cities and rural areas, etc. I wonder, do you have an idea of whether all your transplant eligible patients, the majority are transplanted, or some are just treated, well, not just, but basically treated like transplant ineligible patients? I guess in Korea, because of the age limit, that
most
is
of them
the
will be
major
transplanted
issue.
in the long run.
Sure. In Japan and China?
In Japan, we don't have any age limitation, but usually we do younger than 65 years old, but some institutes do around like 70 years old.
Sure.
Yeah, so it depends on the institute.
Yes.
But so-called transplanter would like to
Do
transplant.
more, so it does vary.
yeah,
between
even in
centers,
70 years old.
Yes.
So,
Sure.
Yeah. In China, the percentage to receive autologous stem cell transplantation is about 20% to 25%. The major reason is the imbalance of the economic development. I think a lot of other patients could be covered for insurance.
So do you see that as a big challenge? I mean, you probably do want to transplant more patients, but are unable to.
Maybe the patients is not willing to receive transplantation. Yeah,
right.
because their cultural background, I think.
That's very interesting. So do hematologists try to overcome that resistance to transplantation?
Yeah.
I guess it's difficult.
We are doing our best to educate the patients that they need to receive the transplantations.
And I guess moving along to relapse refractory patients, maybe I can start with Professor Lee. I mean, in Korea, do you have access to a lot of agents in that situation?
Yeah, in the relapse refractory setting, yes, we can choose several kind of drug, but actually there is some order of used for agents. For example, in case of lenalidomide, we have to use the bortezomib previously. So that is the main issue. The other kind of one is we can use the freely thalidomide and other kind of drug. So main limitation at this time is to use pomalidomide to the patient. We can use pomalidomide with insurance coverage.
Pomalidomide?
You can't use pomalidomide by insurance coverage.
But bortezomib and lenalidomide and thalidomide are available.
Yeah,
yes,
right.
Yes. Yeah. Do you have a view to how you sequence them, or
it depends on the investigator. So there are two kinds of treatment when the patient treated with previously bortezomib. One option is to treat it again with the bortezomib treatment. Another one is change to the lenalidomide instead of the treatment. That is option is depend on the investigator.
And in China?
Yeah, the situation is different for the patient. If the patient is young and unfit, we could recommend he receive the allo stem cell transplantation if he could have some donor.
Does that depend on risk group or high risk or
high,
all of the majority?
You mean the patients after a lot of lines for first relapse? Okay. First relapse for the patients very young, such as less than 40.
Sure.
Although the first relapsed. Yes. And if he didn't expose to the novel agents, we could recommend the novel agent. If he used it, we could combine the traditional chemotherapy and the novel agent together, to get another remission. Yeah.
Maybe I can add our decision tree to what Professor Lee has talked about. Well, we can divide into two categories. For those who are under the age of 65 or over this age of 65. For those under the age of 65 whom probably have received stem cell transplantation prior to disease progression, they may have been exposed to Taldex and Velcade and dexamethasone. In that case, we can decide on either Velcade retreatment as long as they have not been experiencing disease progression while on Velcade. Then we can try Velcade retreatment on a certain government regulation.
Yes.
And also, if the patients did progress on Velcade, then the third line, as a third line, we can apply lenalidomide and dexamethasone.
Sure.
For those over the age of 65, probably they have received VMP as a first-line treatment. In that case, we can apply Velcade-containing agent in a form of Veldex as long as they have been happy with Velcade-containing agents. Or other than those situations, we can apply lenalidomide combined with dexamethasone under the reimbursement policy. Other than reimbursement policy, so far we have not been able to use pomalidomide as a government-funded reimbursement plan. In that case, we can use pomalidomide or bendamustine
Okay.
or whatever agents on patients out of their own pocket.
Oh, right.
Or sometimes I use low-dose chronic use of alkylators, such as daily use of cyclophosphamide, 50 milligrams a day, coupled with dexamethasone 6 milligrams QOD. Sometimes that is effective.
I guess that's more like a palliative
Yeah, sort of
approach,
palliative.
yes.
Sometimes,
Yeah. Sometimes
you can
get a lot,
experience
really
gratifying
long,
response to
Sure.
cyclophosphamide and dexamethasone.
Sure.
Well, maybe you can apply melphalan-based treatment, such in the form of MTP or whatever combinations it may be.
Sure. And perhaps I ask, with Japan, your availability of drugs in the relapse refractory situation would cover the main novel agents.
Yes, actually the end of April this year, we got an approval of pomalidomide in refractory relapse setting, and also the Veldex panominostat is also approved, so that we can use it in a refractory relapse setting.
So I can say in Australia we also now have pomalidomide, but with the specification that one does have to have been exposed to lenalidomide and bortezomib. I guess one of the kind of big developments that we've recently come across is monoclonal antibodies, and I would like to, discuss your experience or with clinical trials or your thoughts about what you heard in the last few days about monoclonal antibodies.
We don't have any experience in using the monoclonal antibody in treatment of multiple myeloma. But from the literature and from IMW, we could know it's a game changer.
Yes.
Some people say that it may cure the multiple myeloma. We are looking forward to use it for my patients.
I'll just mention our experience before I go to the other countries. So we have been involved in the daratumumab trials for relapse refractory. Other centers were also involved in elotuzumab, but not my center. And I do agree, even with our limited experience, that a lot of us do think it may be a game changer. The mode of action is so different, and seems a very powerful agent. How about Professor Hatake?
Yes, we finished to conduct the second line setting of elotuzumab plus RD, and also that we just started to have first line chemo for elotuzumab plus RD in newly diagnosed multiple myeloma. And daratumumab is not my center, but Japanese phase 1 clinical trial has been conducted, and we're waiting for the combination clinical trials.
Yeah, I might mention, so we've completed the relapse refractory trials, and we're just starting the first line treatment of transplant ineligible patients with combination with Velcade, actually, with bortezomib rather than lenalidomide. And I think in Korea you have had the daratumumab
in a
trials
clinical trial setting.
Yes, yes.
Outside of clinical trial setting, we have not been able to use daratumumab because it is not available. But in a clinical setting, we tried daratumumab in combination with lendex, lenalidomide dexamethasone. Other than minor infusion-related side effects, we have seen a very gratifying response, a dramatic response. I think it's really a game changer. Maybe we may obviate the use of transplantation in the long run, if it is so effective.
Yes.
Most of the Korean doctors didn't have any experience to use daratumumab as a clinical trial.
Yes.
So because actually Korean start the clinical trial later.
Yes.
So just to start this kind of trial,
Yes.
and then close to that one. So
That is a
unfortunately,
very
we don't
common,
have we don't have
amongst
any experience to use that
Sure.
kind of drug.
I guess finally we might talk about what has struck you as perhaps other notable developments in myeloma that you might have learned from this meeting. I'm sure our colleagues in the region would appreciate very much your thoughts about what you think the future may hold. So, Professor Hatake,
Okay. Actually, we have many novel drugs which was conducted in Europe or United States. But we also are conducting the global trial as many as possible. But unfortunately, probably 20 to 30% of the new drug come to Japan, but not the 70 or 80% didn't come. That means why the venture company does not have any partnership with Japanese pharmaceutical companies. So that's the reason why that does not come to Japan. So this is the reason, the problematic. And also the age limitation and also the longevity problem on the Japan is so strong. So maybe, the limitation for the chemotherapeutics or induction chemo will be changed a lot. So, and also we need to more drugs because we have a case of prevasive leukemia or extramedullary disease of myeloma. So drug resistance happened. So we must have more drugs to overcome.
Were there any particular agents that struck you as very hopeful for the future? Well, I guess for Australia, I mean, we very much would like to see the second generation proteasome inhibitors. And one particular problem we have is at the moment we cannot use combinations. And with so many of the new drugs, including the monoclonal antibodies, as you know, the greatest efficacy is in combination. So that will be a big challenge for us to be able to use combinations.
Some of signal transduction inhibitors may be very promising in the near future.
Yes.
Especially if combined with currently available targeted agents that already have shown response or activity in the relapsed refractory setting.
And may I ask your thoughts about MRD, because that's minimal residual disease that has featured so highly in the meeting. Do you think that will be a big feature of your management in the future?
Coupled with
Absolutely.
Yes, definitely.
In the search for a cure,
coupled
I
with
guess.
maintenance treatment.
That's right, yes. So thank you very much for coming to join this discussion, and I'm sure our colleagues would enjoy listening to us, and thank you very much for joining us today.